Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds, Premier Education brought to you at no cost. Thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. This week is a great delight for me to present Professor Cypel from the University of Toronto to give us an update about lung transplantation and about some of the work that he's done. I also have my former colleague, Professor Karen Redmond, now based in Ireland, as a discussant for Professor Cypel's talk. So without further ado, let me share my screen. And we're going.
I'm going to talk about ex-vivo lung perfusion and how this technology has been used to optimize the donor pool. So these are some of my conflicts of interest related to this presentation. The goals of ex-vivo organ repair is really to provide more donor organs for all and more equitable access, and of course, eventually improve the outcomes of lung transplantation. As you know, the use of donor lungs amongst multi-organ donors, it's quite low. At best is around 20%. And this is one of the main reasons why we still have patients dying on the wait list for lung transplantation. One of the main reasons why the utilization rate is so low is because the lung is a very fragile organ, and during the process of brain death or a process of DCD, there are several injuries that the organ can acquire, leading to an increase in the inflammatory cascade, which eventually leads to primary graft dysfunction. And so transplant teams are very conservative in the selection of donor organs. Ex-vivo lung perfusion or organ perfusion in general keep the organs alive outside the body and then allow the transplant teams to better examine and treat the organ before transplantation. This is the new generation ex-vivo lung perfusion perfusing a DCD human lung here prior to transplant. As you can see here, the ventilation and the perfusion parameters are very protective, and that there is no need for blood to maintain the lungs well, in contrast with some of the other solid organs. This is just to illustrate one of our first ex-vivo lung perfusion cases. This was a donor that had a motor vehicle accident and 25 units of red blood product transfusions. The lungs had some pulmonary edema, but multi-transfusions and also PF ratios were in the low 200s. You put this organ on EVLP, the lungs have some edema at 1 hour and then clears up by hour 3 with improving gas exchange function. So this shows one of the most simple aspects of EVLP, which is clearing some neurogenic pulmonary edema. This is the X-ray of the recipient with excellent function after transplantation. There have been several publications from our group, especially, but also others on not only short-term but long-term outcomes after normothermic ex-vivo lung perfusion. This was the first publication of normothermic perfusion, in fact, for any solid organ, which showed the success of 20 patients transplanted with lungs that were otherwise declined for transplantation. Since then, we have done over 1,000 clinical ex-vivo lung perfusions in our center. This is a recent publication from our team. And here again, it shows that this technology has contributed to at least a 50% of growth in transplant volume. And when you look at the outcomes of these patients, they are excellent, and they are at least equivalent to the patients that received lungs direct to transplantation, which were already deemed to be good to start with. And there is a lot of innovation coming up in this area, both from the assessment standpoint, but also from the therapeutic standpoint. Again, this is just showing here some of the outcomes of this over 1,000 EVLPs in our center. And you can see here the survival curves are very similar Interestingly, the hospital length of stay for these patients is significantly lower than the patients that receive conventional lung transplantation. Again, even considering that you are transplanting lungs that are higher risk to start with. Very importantly, this technology has also allowed us to expand the geographics reach of our donor population. And as you can see here, about 30% of our donors come from either other provinces in Canada or from the United States, and will go as far as California or Alaska to take lungs. Now, with 10-degree lung preservation, this has even facilitated further. Types of donors that we use on EVLP, you can see here that about half is brain dead donor, and then half is controlled DCD, but we do have also expanded to medical assisted dying, like euthanasia donors, which is allowed in Canada, as well as uncontrolled DCDs. This technology is excellent for that. I also like to mention the indirect benefit of having EVLP available. It does also increase your number of transplants coming out of non-EVLP cases. And this is an example. This is a 72-year-old donor that was declined in over 60 programs in the United States. Best PO2 172. The donor had a tracheostomy, declined by multiple centers at MSSA on BAL. Normally, I would not send my team out for this donor if I didn't have EVLP available. We sent and we got to the donor, and basically the lungs look great. And we end up transplanting this lung without EVLP, direct to transplantation. And this is one of the ways, again, that you become more aggressive in going to look in donors, and many times you don't need EVLP and you can still go ahead to transplant. So this is the indirect benefit, and this is the X-ray of the recipient with a good gas exchange. Very importantly, we have pushed the boundaries a lot, and using high-risk donors and high-risk recipients. And if you look at our 30-day mortality has gone below 1% more recently, becoming very safe procedure to be performed. Again, even pushing the boundaries in donors, basically EVLP take the risk out of the high-risk donor organ. Now, this technology can be used not only for assessment, but also for treatment and repair. There are basically three eras of EVLP. The era one, which we went through already, which led to about 100% increase in volumes just by giving a better organ assessment. Then we have the second era, which we provide personalized therapies like antibiotics, thrombolytics, and anti-inflammatory drugs. The goal here is really, again, to improve the donor organ to make it transplantable. This is also being done extensively. And the area we're entering now is the more exciting one, which is the using therapies actually to improve patient outcomes, not only to get more organs for transplantation. So some of the example of this therapy is the use of thrombolytic therapy in donors that have died of massive PE. This is using streptokinase during EVLP, showing decrease in pulmonary vascular resistance and successful transplant. We have done this several times now. This is the use of antibiotics to decrease the donor microbiology levels of the most common donor bacteria. Again, take advantage of not having other organs in the circuit and using high-dose antibiotics. We have also used light therapies to inactivate chronic virus infections. This is the example for hepatitis C, which is very prevalent in North America. And we went on to do a clinical trial using ultraviolet C light during ex-vivo lung perfusion and showed that this was effective in preventing transmission from donor to recipient. As you can show in this graph here, the use of UVC is very effective to inactivate virus. We can also target cytomegalovirus using this fusion toxin protein that binds to cells that are latently infected with CMV. And again, the goal here is not to get more organs for transplant, but is to decrease morbidity of the recipient after transplantation. And we're very excited about this, and we're starting some clinical trials. This is just to show in the preclinical level how using this fusion toxin protein significantly decrease the chance of viral reactivation after transplantation for mismatches. And then another strategy that we are very invested on is really to convert blood type from organs. We were the first to demonstrate this back in 2022, and subsequently there are other groups are showing that in kidney and heart. But basically, we're using a specific enzyme to delete the A antigens from the organ. There is a big discrepancy between the blood type from donors and recipients, and so all blood types have to wait a lot longer. They have higher waitlist mortality. Just an example, in our center, the wait time for a blood group A, AB, B, and O can be very different. So the median wait time is 3 times at least higher for O blood type, and they also die more on the wait list. So if you can create universal blood type organs by removing the antigens from the donor graft using these specific enzymes, the recipient antibodies wouldn't have anywhere to bind, and we wouldn't have AMR. And hopefully by the time the antigens re-express again, you could have accommodation, as we've seen in kidney transplant. Again, this is just histology to show how effective these enzymes are to remove these antigens. When we circulate these organs with whole blood full of antibodies, we can see in the blue line that these antibodies stay in circulation because they have nowhere to bind, whereas in the control group in red, they completely disappear from circulation because they are binding to the tissue. Of course, there could be some antigen re-expression, and then we're doing some CRISPR genome editing to try to permanently delete the synthesis of A antigens in the organ. Now, other strategies with CRISPR to enhance the local immunosuppression of the organ itself by increasing IL-10, which is an anti-inflammatory cytokine within the organ. You can see here that after a few days, the IL-10 goes up, and you have a kind of a permanent production of local immunosuppression in the organ, and hopefully we can then use less systemic immunosuppression in the patients. This is a study from a group in Germany that showed that you can silence HLA with lentivirus approach during ex-vivo lung perfusion. And they have now some pigs over a year without immunosuppression and without any rejection. So very exciting work. And then finally, from a therapeutic strategy, mitochondria seems to be a critical organelle in organ preservation. And we have shown this when we preserve organs at 10 degrees, mitochondria is much better preserved. So how about actually transplanting healthy mitochondria to the organ during ex-vivo lung perfusion? And that's what we've been doing more recently. And it has shown a dramatic effect to repair injured organs during EVLP. As you can see here, the dynamic compliance and gas exchange function much improved in these organs that received mitochondria, which was extracted from heart muscle. And finally, I'd like to show the concept of ex-vivo organ repair centers. To apply all these therapies, it may be an advantage to centralize EVLP. I know the UK has been implementing that, and we have helped some of the logistics. We have this already in Canada for several years, and then in the US via lung bioengineering, this is also available. And you can see here, basically, the organs are sent to this facility, which only basically treat donor lungs. And they have really increased the number of lungs that have been referred to them over time. So all the centers are finding this very beneficial, of not needing to have an ex vivo lung perfusion in their own hospital, but to have that available in a centralized fashion. So I'll finish here, and thank you very much again for the opportunity to present this.
Well, thank you very much. That's an amazing presentation. I think so exciting to see how the field of transplantation is moving on. Karen, you've had quite a lot of experience in this field. I mean, I remember the time when you were still in Harefield, already starting the EVLP program here. And how do you think, I mean, listen to Marcelo's talk, the apps really pushing it to all the benefits. That's so phenomenal. How much of that is the UK and Ireland able to leverage on at the moment where we are?
Well, I think we're really down on transplantation activity, which is a concern, and it has been highlighted in the media of late. So if you look at the numbers in the UK and Ireland, we're probably about 2 per million of the population, 3.5 for hearts. And in the US, some centres are between 10 to 12 per million of the population. So we have to reflect on this and wonder why our transplantation activity rates are so low. Certainly, the Society of Cardiothoracic Surgeons are looking at this in a collective way as a group to see if we can address this problem. Some fellows have returned from Toronto and have started working in different transplant units within the British Isles, and they are helping to navigate introduction of EVLP into those units. I think if we can get EVLP more active in those units, there is an opportunity during daytime hours to assess every organ as long as there's a suitable recipient, audit the process and see how we can increase activity. The Toronto group did publish their experience in the JTCVS in 2026, over 1,000 EVLP procedures with approximately 65% going on to being transplanted. So it's definitely, they would say it would increase activity rates. Other US national platforms have also published in 2025, and they've looked at 23,000 lung transplants performed in the US, but only 813 involved EVLP. Now, they noted that there was no difference between the two groups. The PGD3, which is primary graft dysfunction levels that are kind of significant enough, was about 14% between the two groups. So I would say that, we can be a little bit more reassured that in relation to outcomes, there is no difference between an EVLP lung and a lung. And I suppose in the climate where we're not transplanting enough, we have to look at these platforms, even though they may be resource intensive, to see if we can increase numbers.
But how many centers in the UK offer this EVLP? All the transplant centers.
At the moment, it's three in the UK are offering EVLP, and it's only really recently that they've reintroduced it with the return of fellows from places that are high volume EVLP centres such as Toronto. What has helped significantly, I think, as well is there is a major issue around staffing. Shortages. A lot of surgeons aren't going into transplantation. It's such an onerous and difficult job and stressful job to be in. But Marcelo mentioned the fridge. So there's now, an understanding that you can put lungs into a fridge, preserve them in temperatures depending on the device you're using, up to 10 degrees. Helps to obviously maintain mitochondrial activity. And you can start normal working hours the following day, 8 a.m. with awake staff. And we know from a quality point of view makes a difference. So what you could do is put these lungs into a fridge the following day at 8 o'clock, put the lungs onto an EVLP circuit. The Toronto group, it takes 30 minutes, and they don't use consultant surgeons. They use trained surgical care practitioners. It can be done, and by maybe 10 or 11 o'clock, somebody could have a look and see whether these organs are suitable for transplantation. Certainly, what you're doing is you're delivering on the wish of the donor family, which is to basically, support the people. It's the true meaning of life after death, and there are people dying on the waiting list. There are recipients dying all the time. So, it's an absolute must that we need to move forward with this.
Does every transplant center use EVL, or every center that harvests the organ have access and uses EVLP in the UK?
No, no. And I think collectively we need to work as a group and we need to deal with the commissioners in different countries. And we need to make sure that as long as there's a suitable recipient, that every organ should be looked at in detail. And that requires, investment. It requires resources. And I suppose it requires passion amongst the people, and we need to bring these fellows that are coming through into transplantation, and we need to get a work-life balance for these people that they're happy to stay in these roles.
Dr. Therese is asking, what is the additional cost to add EVLP into the donor harvesting program, say for the United Kingdom?
It varies depending on the service provider. There are different groups. Some systems use a closed atrium device and some systems don't. So there's probably about 4 to 5 different systems out there. But realistically, you're talking at least 25,000, I would think.
Oh, wow, that's incredible. And can I also ask, I mean, at the moment, the UK is probably in the infancy or just reintroducing EVLP, whereas centers like Toronto are just making, leaps ahead. Organ repair, for the donor organ repair, Marcelo was saying that even if you have if you die of a massive PE, presumably they fish out the major clots and then put streptokinase. Do you think that's going to be the next step or level, which is organ repair with EVLP in the UK to increase the pool of donor lungs?
I think, to start in kind of at small steps, we should be looking at, for example, you mentioned going out and you might find that this donor lung that isn't perceived to be usable is actually usable straight to transplant. It'll increase activity. Then you'll have people who will have, lungs that aren't quite right because they have, bibasal atelectasis, some secretions due to some minor aspiration in the airway. You might find that there might be a small clot burden, but not a lot. Those people can come back, be assessed, and be reconditioned. So there's extended assessment of marginal donors reconditioning, and they will be transplanted. Beyond that, you're stepping up a little bit to things like major PEs, or we talked about uncontrolled withdrawal, from trauma patients, etc. So that would be a step up, but certainly would be something to look at. And then there's the logistics side of it. Sometimes we struggle to get a suitable recipient in time because there is, no the cross matches them through, or you have to cross match a second patient to be able to deliver on the matching process. And certainly, as we need to work more collaboratively, because if one centre doesn't have a suitable, either surgical workforce or resources to run EVLP, or they do not have a suitable recipient at the time, we really need to be moving these organs or surgeons or recipients around the different transplant centres to make that transplant happen. So certainly in the Republic of Ireland, we'd be very interested to collaborate more with NHSBT, because you can see from Marcelo's talk, oh my God, they're moving all around Canada and the US, and so it allows for, I suppose, as he talked about, there is inequity around access to transplantation depending on where you live. I mean, that should never happen anymore. There should be parity. Everybody should have access, if a suitable organ is available.
Toronto is championing the cause for organ repair centers. That's another phenomenal concept, right? So theoretically, at some point in the future, you could have hospitals and teams dedicated to organ harvesting, organ repair, and then putting it out to to the whole country, rest of the country, taking in organs. And that to me makes a lot of sense, because once you have a specialized team doing organ repair, it's going to be so much better than 5 hospitals, 3 hospitals, each trying to do it individually or separately to pool their resources to one major center in the UK, perhaps in the future where all the organs are first retrieved, and those that can be EVLP'd, you have, I don't know, how long is it, a day or so, where you can actually look
I think it
at
takes about 2 hours to kind of make a decision, really. Now that's different to treatment plans, as you mentioned, or alluded to. Certainly, this came up. We actually had a meeting yesterday and all the transplant surgeons from all of the transplant units were together, and we collectively did talk about the idea that there would be a central hub of activity, not just for EVLP, but for all retrievals. Should we have one hub where all retrieval teams are cited, and that creates, I suppose, that the experience is shared and that it's appropriately resourced. So again, it is up for discussion, it's up for debate, and certainly it would be something that I would support for sure.
Yeah, I think that having done so many retrievals in Cambridge, I think that'll be a really, really good thing because the expertise, when currently the system, and I'm sure many countries as well, they use registrars to do the retrievals or maybe junior consultants, and would you come and go? But if you have
Mm.
like a team working 10 years on retrieval, can you imagine how slick that team would be to retrieve the organs, to get the organs back to base, nurture the organs, improve them, and then put them out for as a call. I
I
think
would
that
absolutely agree with that, Erica. I think that that is something that we should and are discussing through the society.
Dr. Sultan is asking, is the history of cancer in a donor still an absolute contraindication for donation for lung transplantation?
Not always. There are, there are some absolute contraindications, such as lung cancer, for example, but there are other cancers or malignancies where it's not an absolute contraindication. And, for example, I might, look at somebody who has a very early stage prostate cancer and see that as being acceptable. And you've got to, navigate when you get a donor offer through where we are with the recipients. You have to understand, like, these people are on these people are on, high flow on the ward and are actively dying. And some of my patients might have, a few days to live. So if you go and talk to them, you say, I've got a donor that's, extended criteria because there's a, history of cancer, or they might have, be, infected with hepatitis C, etc. All of these recipients they have, it's either this or they're going to die. That's the reality. Like, this is salvage surgery for these people. And the outcomes are excellent. They're more than acceptable. We have to be careful about, history of cancer, about how the cross match works, and what level of immunosuppression we'll give these people, especially if they're in the older age category over 65 as recipients. But certainly, I wouldn't say no in all cases. It requires discussion, and there are, guidelines out there through the ISHLT about what you should and should not accept.
Professor Bass is asking, what is still the major reason for failure of lung transplants at around the 5-year mark?
That's multifactorial, and it depends on the unit and who they're transplanting. So, for example, in Ireland, we do transplant a lot of we do a lot of single lungs into IPF recipients, for example, because that's the kind of cohort of people coming through to us. Other people would have different people's pulmonary hypertension, COPD, whatever. But we would you could talk about graft failure further down the road. But other areas of concern would be things like them developing malignancy, in the native lung or even in the donor lung. Other conditions will arise, really due to the complications of immunosuppression. So when Cypel was talking about this need to basically, from an immunological risk, sterilize the lungs before they get transplanted, I mean, that, or using pig organs, where they've also, I mean, that will revolutionize how we manage end stage lung failure globally.
Absolutely. Well, as always, there's so many questions and not enough time for answers,
Thank
which
you,
leaves
Eric.
me to thank Marcello and yourself, Karen, especially for University of Toronto for really spearheading and leading the world in the field of lung transplantation. And they have made so much improvements, which no doubt led to improved quality and survival of many, many patients with end-stage lung disease.
Yes, I'd like to thank them too, Eric. They have mentored us all, and certainly, we all aspire to be like the Toronto Group.
Excellent. So thank you once again to our sponsors, AstraZeneca, Medtronic, and Medillion Science of Care, and we'll see you all again next week. Bye bye, everybody.